we need to talk about treatment-resistant depression, or TRD. It's one of the biggest challenges in modern psychiatry, and frankly, it's a massive public health issue that puts an incredible strain on people and on society as a whole. So let's get right into this report and break down what it is, who it affects, and most importantly, what we can do about it.
Just to give you a sense of the scale we're dealing with, let's start with a number, a huge one. It's estimated that over 100 million people around the world fit into one or more definitions of treatment-resistant depression. This isn't some rare niche condition. It's a full-blown global health crisis.
So what do we actually mean when we say TRD?
Well, the most common clinical definition, the one that regulatory bodies like the FDA and EMA use, is pretty specific. It's when a patient doesn't get better after trying at least 2 different antidepressants. And this isn't just a casual thing. It means the treatments failed even when the dose was right, the trial was long enough, and the patient was taking the medication just as prescribed.
But, as you can probably guess, it's not quite that simple. One of the biggest obstacles in even tackling TRD is just agreeing on what it is. This definitional challenge makes everything from research to patient care way more complicated. So why is it so hard to just nail down one single definition? You might be thinking, what's the big deal? Well, without a consensus, every research study might be looking at a slightly different group of people, which makes it incredibly hard to compare results. It also creates a ton of confusion in clinical practice. And that directly impacts patients, because if we can't agree on what we're treating, how can we be sure we're giving the best care?
And this slide really shows you what I mean. There are several different models out there trying to define and stage TRD. You've got the Thays and Roche model, which is all about how many types of drugs have failed. Then there's the Maudsley model, which takes a broader look at things like how long the episode lasts and how severe it is. And the MGHS model tries to measure the intensity of each failed treatment. The key takeaway here is that each one has its strengths, but also its weaknesses, which is exactly why we're in this definitional mess.
Now, this brings us to a really critical idea: pseudo-resistance. It's a bit of a plot twist. It turns out that a huge number of cases that look like TRD, we're talking up to half in the early stages, aren't true resistance at all. Instead, the treatment isn't working because the dose was too low, it wasn't given enough time, or the patient just couldn't take it consistently. It's absolutely vital to rule this out first before labeling someone with TRD and moving to more complex treatments.
Okay, now that we've wrestled with the definition, let's move on. Let's look at just how widespread TRD is and the massive ripple effects it has on people's lives and on society.
The numbers here are pretty staggering. In a typical research setting, about 30% of patients with depression will meet the criteria for TRD. But look what happens when you get stricter with your definition of success. If you say success means full remission of all symptoms, like they did in the famous STARD study, that number can shoot up to 55%. This just goes to show that how we define getting better dramatically changes the perceived size of the problem.
And the fallout from TRD is just devastating. It really hits on 3 main fronts. First, the economic burden. TRD is responsible for over half of all the financial costs tied to depression, mostly from higher healthcare use and lost productivity. Then there's the physical health risk. It's strongly linked to a higher risk of heart disease, obesity, and diabetes. And the most tragic impact of all, the rates of suicidal thoughts and completed suicide are heartbreakingly disproportionately higher for these individuals.
When we dig into the risk factors, there's one that stands out with painful clarity. The report makes it very clear that a history of childhood emotional abuse is a powerful predictor of not responding well to standard antidepressants later in life. It's a stark reminder of the deep connection between early life trauma and long-term health.
All right, so we've laid out the problem, and it's a serious one. But what can we actually do about it? Let's turn to the proven, evidence-based strategies that are available right now to manage TRD. One of the biggest game changers to come along in recent years is esketamine. It's a nasal spray that's used along with a standard oral antidepressant, and it has shown remarkable results. It works quickly and effectively, not just in a crisis, but also for long-term maintenance. It's especially good at tackling symptoms like anhedonia, which is that terrible inability to feel pleasure.
Now for a treatment that's been a gold standard for a very long time: electroconvulsive therapy, or ECT. As this quote from the report states, it's still seen as one of the most effective tools we have for TRD, both for getting people well and keeping them well. In some studies, it achieves remission in nearly half of patients.
ECT is actually part of a bigger category of treatments called neurostimulation, which use energy to modulate brain activity. There are several powerful options here. We have repetitive transcranial magnetic stimulation, or RTMS,
that Zhongfu Jingru Ciji in Chinese, which is FDA approved and has a great safety profile. There's a newer, faster version called intermittent theta burst stimulation, or ITBS, in Chinese, 间歇性自的波脉冲刺激, which can get results in just 5 days. And then there's vagus nerve stimulation, which is an option for people who've had many treatment failures.
So where does talk therapy fit into this picture? Well, this is a really important distinction. The evidence just doesn't support using psychotherapy by itself for TRD. However, when you use it as an adjunctive treatment, meaning alongside things like medication or neurostimulation, it provides huge benefits. It can really help improve coping skills and a person's overall ability to function in their daily life.
Okay, so that covers the tools we have in our toolkit today, but what's next? Let's look to the future, because the landscape for TRD treatment is really starting to change in exciting ways.
This table gives us an awesome snapshot of what's coming. Psychedelics like psilocybin are showing incredible promise for rapid and lasting relief, and they're already in late-stage trials. We're seeing new drugs that target completely different brain systems, like glutamate and GABA. Digital psychiatry is creating apps and tools to help monitor and treat the illness. And finally, the Holy Grail, the search for biomarkers, which aims to bring precision medicine to psychiatry so we can finally predict which treatment will work best for which person. It's a huge shift towards more personalized and faster-acting options.
So when you pull all of this together, what does a modern, smart approach to TRD look like? This report really boils it down to 3 fundamental principles. First, we have to stop wasting time on treatments that aren't working and shorten those delays. Second, we need to reach for the proven, evidence-based therapies much sooner. And third, we have to get better at optimizing our clinical decisions by using consistent definitions and better monitoring to close that gap between what we know and what we do.
All right, let's wrap this up. Here is your take-home message. Treatment-resistant depression is incredibly common, it's severe, and it's costly. Managing it is tricky, partly because we can't all agree on a definition and because of that pseudo-resistance problem. But, and this is the important part, we have effective, proven treatments available right now, like esketamine and neurostimulation, that offer real hope beyond standard pills. And the future looks even brighter, with new scientific approaches and precision medicine promising to bring even more targeted, effective relief to the millions who've been waiting for a breakthrough.